We are aiming for a short and crisp session, so that the basic aim of this session is to give an idea what we are doing or how can we help you guys um, to crack your Edic 2 exam. You don't have much time left. We are at the end of our routine course, but again, we are doing three mock exam, which can be very, very beneficial as a practice before the real battle. So it's always handy to get evaluated by someone else before going into the exam, which helps a lot. Um, Plus, the examiner, we have a broad range of examiners. I think more than 15 examiners are enrolled this time, and they will share their experience who are AD qualified, and they will share their experience how to tackle, how to answer, what the examiner are expecting from you. So all these things will be discussed in this three mock exam, which I think will be very, very beneficial for people who have already enrolled to our course, no doubt about it, but definitely people who have not enrolled due to any reason for our routine course, but they can take the benefit still and capitalize in this limited time that they are left with. That's basically the message that I want to pass on. The first part of this session will be like around 15 minutes of some discussion around the computer-based scenario or CBS, how to approach and what are the things you need to keep in mind. And then Dr. Tapas will go through a CCS discussion, uh, talking about few of the important tricks and few of the important things that you need to apply and need to know before jumping into the exam. Tapas, when you think
Yes.
like we should be starting, then I'm happy to start.
Yeah. So I'm just starting the initial maybe 2 minutes time for the introduction part, what we are doing and how we are actually planning to conduct the course. So wish you a very very good evening, and most of the friends who have joined today are from Saudi Arabia, Egypt, and Middle East. So thank you friends for joining before time, I would say. So very well appreciated. And before like going into the nitty gritties of the exam pattern as well as how you should prepare, so the quote that is right now very relevant is work that is right now needed is very hard. We have multiple distractions in our life, maybe the professional, the family, as well as the current scenario of having so many attachments as well as the commitments. And the most important thing, everybody agrees, Dr. Sanand has also told, time is very short. We have only, I would say, 50 days or so remaining before your exam will be happening. So the exam days are fixed since long, and as I have now also confirmed, it is on November 26 and 27. Now, this is something which I wanted to share with you before I would be handing over to Dr. Sanant, that winners don't do different things. They do the things differently. And that's why we are here from the 360 Critical Care Academy, and our course that we conduct over years are actually the courses that have been planned, changed again and again, and we are now doing the live one-to-one, the interaction as the examiner as well as examinee. And the examiners are also those who have qualified in the recent Edic 2 exams. So they are very, I would say, the fresh examiners, those who have qualified. So they know how to answer it smartly in the exam. And maybe you know the answers, but the answers have to be short, precise, and also to the point, because you have very limited time. Once you start, the CCS would be over in maybe 1.5 hours. Once you start the CBS, the whole 4 or 3 worst, the tables would be finished maybe in 90 minutes or so. So you have very less time to answer, think it, and again rectify it. So pull your socks up, we are here to help you in next, maybe I would say 40 minutes or so. And let's start with the first part, which is the CBS, computer based scenario. Why we have again planned CBS? Because what we got the feedback from our own the candidates who have appeared in the last 5 or 6 examinations, that CBS is something which is actually the crux. So if you do well in the CBS, the chances of clearing the final Edic 2 is more, because the CCS average, what we got the feedback and the candidates who have appeared in our course, so the confidence level is tremendous high. And CBS, if you know well, you have gone through all the videos that we have actually recorded in last 11 weeks, will be definitely helpful. And also the questions that Dr. Sannat would be now like sharing with you, so he would be summarizing how well you have to answer it in the real exam.
I'll be discussing only five CBS, and let's see how you people approach this, and then we can talk about it a little bit, right? The first question is a um, chest X-ray, and it is of a patient with a triple vessel disease undergoing a cabbage, and post-op was put on mechanical circulatory assist device. Now, the question is identify the device and identify the abnormality. If anyone can volunteer from the audience group, that will be great. Let's see. I mean, as Tapas was saying, there is no judgment about who can answer or who can't, but let's try if anyone wants to.
You can post in the chat box. Guys, only 1.5 months is left. So we need to like, definitely answer something. You cannot keep quiet in the exam. We need the first volunteer.
Sorry. Tapas, I think they are enabled for replying or not. I'm not sure about it.
They can post in the chat box. Bhagyasri, am I right?
Yes, sir. Let me check once.
Yeah, please check. Yeah. They can post. Yes, I got the message. Yes. Thank you, Dr. Ajmat. Yeah.
Okay, if nobody is answering, then I'm probably not going ahead. Otherwise, it will be a very boring session.
No, he has
I can
posted
feel.
IABP. He has posted
All right,
IABP. Yeah.
that's
Okay, sir.
correct. And what's the abnormality? Can anyone tell there? Santosh has said position. Yeah. What do you mean by position? Is it? Yep, that's correct. High position. Now, how do you determine which is high or which is a low position? What is the criteria for it? Somebody has written carina, but above the carina, below the carina, where the tip should be. At the level of carina. Yeah, you can tell at the level of carina based on which literature you are following. So that's the appropriate answer. So the complete answer is a so identify the device. In this case, I can argue what are the device. So one is the IABP, definitely that's a device, but there are other devices also. There is a central line, there is a endotracheal tube, there is a nasogastric tube. There are lots of chest drains also. We can tell them as device. So unless the examiner says you not to talk about those things, you need to talk about it. So the devices here are the most prominent or the most important one is an IABP, but at the same time there are other devices present. Which phase of the what do you say cycle of the IABP is this X-ray taken? So it is inflated or partially inflated, right? The tip is slightly higher up in the position where it should ideally be. It is much higher than that. That's the abnormality. I put in a IABP X-ray because this is a very important question in the Edic exam. They talk about various questions on IABP, whether on the X-ray or whether the waveform, IABP waveform. Though nowadays most of the devices are advanced auto triggered one, but they are very fond of asking what is the abnormality in the IBP waveform. In different stages of our whole course, we have talked about that. Like there are five different scenario that can happen in an IBP, whether it is early deflation, late deflation, early inflation, late inflation, and incomplete inflation. So there are four or five scenarios that can happen in an IBP question. Okay, so you guys need to know the waveform, how it looks in case of early inflation, in case of a early deflation, or late inflation and late deflation. The waveform, you have to be very, very familiar about it, because that's a very, very potent question in the exam. They can ask you about it. Also, on the X-ray, the position of the IBP, which phase of the IBP cycle they are, they can ask you about it. This can be a question associated in a CCS also, because the CCS, there is a case scenario that turns very frequently from one side to the other side. They can show you a post cardiac surgery patient as an CCS, and they can ask you about the use of IBP, how does it work, what is the principle of mechanism of action of IBP, and all those things. So basically, 4 5 things you need to remember about IBP. First is position, X-ray, then the waveform, mechanism of action. Usually they don't ask about literature around it or evidence around it, but it's always good to know about what's the evidence behind its use in cardiac surgery. So 4 or 5 things that you need to be very, very acquainted about IBP in the exam, and it is a very, very important question in the exam also. All right, let's talk about this one. Identify the image and what is the significance of the square shape. They are very specifically asking about square shape. There are multiple squares in it. One is that one. Usually it is a diamond, but now it is a square in this figure. And what about the other squares? So what is the image called as, or what type of image it is, and what is the significance of the squares they're asking? I can't see the chart. That there are four answers to that. So yes, it's a forest plot. Somebody's answer. But what about the significance of the square? Confidence interval? Not exactly. Anyone, any other person wants to give a guess? Each study is presented as square and based on weightage. Yeah, that's correct. Smriti is correct. So each study, the weightage given to the study is the size of the square. Um, yeah, so that's correct. So the answer is a forest plot. Size of the square is the weight of the study. Position of the square, again, post estimate the odd ratio. So whether it is favoring the control or whether it is favoring the test. So that's where the position of the square will be. A little bit more detail about it. So this is again a similar forest plot. The forest plot usually have a diamond rather than a square, as the combined effect represents the combined results of the trial. The results have statistical significance. If the diamond result does not cross the midline, which is the odd ratio of 1, it should not be crossing or touching the midline to tell whether it is significant or not. The position of the square is the point estimate of the odds ratio, wherever it is. So whether it is in this case where the odd ratio is around 0.1, or whether it is far away 0.01 or like that. So where the position of the square is the estimate of the odds ratio. The size of the square we talked about, weight of the study according to the weightage rule in the meta-analysis. Usually it represents the sample size and statistical power of the study. Again, the x-axis is the odd ratio, and the y-axis is the different studies, which are usually put in an alphabetical manner. So they can ask you about a forest plot and ask you to explain the parts of a forest plot. Similarly, they can ask you about a funnel plot, why the funnel plot is used, what is the position of the circles represented in a forest plot, what is the significance of studies concentrated in bottom or on the top of a funnel plot. They can ask you all those things about funnel plot. Similarly, they can ask you about a Kaplan-Meier curve. What is the use of it, and how do you interpret the result based on the Kaplan-Meier curve? So these are very visual questions that can be asked in statistics. So make sure that you look at least 3 or 4 things in statistics before going to the exam. One of them is this one, the forest plot, funnel plot, Kaplan-Meier curve, These are the three important things to look before the exam and what each point means in that curve. Now, this is a surgical critical care question. So you have a 78-year-old diabetic male who had undergone an anti-resection with anastomosis of a rectal neoplasm 24 hours ago and showed sudden pain among the soft tissue with right flank pain and a fever of 39 degrees. And interpret the image, what you see here, and how do you put the image in the clinical context. Any takers for the answers? Okay, subcutaneous emphysema, but how do you put a subcutaneous emphysema in context for someone who has a right flank pain with fever? Yes, necrotizing fasciitis. All right. Now, how do you manage, and do you know about the scoring system that is used for this type of disease entity? Um, I am not sure what does that NF means. Yep, that's the correct answer by Santosh. Um, all right, let's talk about it in little bit detail. So, necrotizing fasciitis, again, this is a recurrent question in the exam. They can show you a picture with signs of necrotizing fasciitis on the picture, or they can show you a CT scan, or just can show you some sort of laboratory abnormality with a renal failure, high CK levels, all those things fitting into a clinical picture, and then can ask you about antibiotic of choice or how do you manage. So initial thing that you have to talk about is source control. So nothing comes ahead of source control. Obviously, you'll start the antibiotic, relevant antibiotic in the starting because that's the immediate thing that you can do. But source control has to come in the beginning. If you miss that point, then you will not get the mark. Depending on which guideline you follow, based on your institutional practice, talk about the antibiotic, but tell them one answer rather than giving them options. So it's not preferable to say that, oh, we can start a beta lactam with a gram positive cover. This is not an answer. You have to tell very specifically, I will start meropenem at a dose of this much, with vancomycin at a dose of this much, in this case, with clindamycin or not. Up to you, whatever your institutional practices. Give exact antibiotic and exact dosing. All right. There's no point saying a class of antibiotic like a BLBLI combination or a carbapenem. There is nothing called as a BLBLI antibiotic. So this is a class of antibiotic, but they want a specific answer. They have to talk about a specific antibiotic and dosing in the exam. The examiner usually corrects those mistakes from the candidates. They'll ask, okay, you said carbapenem, but which carbapenem? Then you start your answer like saying meropenem, but you lose time in that discussion. So you don't want to lose that time. You have to be very specific in the CBS. All right, let's go to the answer as I told. So necrotizing fasciitis is air density collection with edema. All those things we can talk about. Immediate surgical debridement or source control, antibiotic cover. Hyperbaric oxygen, you can say, but this is not an acute management that you do. But that can be an option for the answer, but your major mark will be first 2 points. We talked about the score. So learning score, you look at a number based on various parameters and then decide the risk of the necrotizing fasciitis, low risk case, intermediate or high risk case. So based on the cumulative number that you get. So, I mean, it's not very rampantly used clinically, not very robust evidence base behind it. But again, in this exam, they talk about depth of the knowledge and breadth of the knowledge. So this is more of a depth of the knowledge rather than the breadth of the knowledge that you have. So how much you know about necrotizing fasciitis, that's what they are going to assess, but you may or may not get this question. All right. Fourth question, a 30-year-old male with head injury was on ventilator. He was withdrawing from painful stimulus. His pupillary responses were equal and brain CT scan showed bilateral frontal contusion with subarachnoid hemorrhage. Blood pressure was 100 by 60, saturation of 93% on a zero point 0.6 FiO2. Temperature is 100 degree Fahrenheit, and blood sugars were 70 milligram per deciliter. He has been nursed with a head elevated at 45 degrees. As the ICU doctor, you decided that the patient requires a central line, and you are going to approach or the wife have approached you, um, um, or the doctor has approached the wife for informed consent. She is apprehensive about the possible complication and wanted to know if you can avoid the invasive procedure and about alternatives that are present. What ethical principles apply in this setting? Again, this is a very important question because we tend to neglect these chapters in the before the exam, specifically the ethics or organ donation or some what do you call ICU administration. Those are the silly, no, I'll not say silly, but those are the high ill topic that you'll get one question each from them, and it doesn't take much time to read through the important topics in there. In this course, we have discussed about few of them, and you will recurrently encounter such questions which are a bit unusual for this exam, but they are repeatedly asked. So, what ethical principle is applied? Can anybody answer there? No, no, there's no answers yet, so I'll not go forward unless I get an answer. Yep. Do no harm, that's correct, but there's a name to that ethical principle. Yes. All right. Yep. All right. Let's see. So first of all, autonomy, because you have given the choice to the patient or patient's wife. Um, you definitely tell that the patient needs a central line, but again, we're approaching for a consent. That means they have a power to give you their agreement or non-agreement. So that way you are preserving the autonomy of the patient or the relative, and it's a non-maleficence because you are not thinking of any harm to this patient. This is an important procedure that needs to be done. You have a clear disclosure of the procedure, and this is necessary. That's why you are approaching. So these are the two major ethical principle that is applied in this case. Sometimes you will struggle whether it is a beneficence or distributive justice or some other ethical principle, but at least you need to name the four ethical principle there in ethical consideration. And there's a good chance that you may get 50% correct. So you need to know at least those 4 points like autonomy, beneficence, non-maleficence, and distributive justice. So at least you know those four principles. In the heat of the examination, you may not be very attentive to say, you may say beneficence for non-maleficence, but at least you utter those four and the examiner can tell you, oh no, no, do you really think that, and then you can have a half a minute to think about it, and okay, so these are the two principles that is applied. So my point is that these are very, very high yield topic where you get one question for your preparation for 5 or 10 minutes of reading. So make sure that you do read these topics before going to the exam. Um, the last question here from my side, a 32-year-old primary gravida underwent normal but prolonged labor at 38 weeks of gestation and gave birth to a child. 1 hour later, she complained of sudden shortness of breath, severe anxiety, chills, and vomiting. Vitals: BP 78 by 56, heart rate is 126, saturating 92%, respiratory rate of 28, and 2D echo is done, which is a static picture. In the exam, you may get a dynamic picture. You can have a better idea. What is your likely diagnosis and how to treat the shock refractory to inotropes or vasopressors? Any answers? Um, anyone else? Yep, all of them are possible differentials here. Hmm. All right. Okay. Oh, somebody has said IABP. All right. Let's go one by one, right? Lots of choices coming up. I think the last one is the most possible one, amniotic fluid embolism. I will tell you why. Because the patient had there is a trick word here which means a long prolonged labor. So the chances of having a amniotic fluid embolism is more if the labor is prolonged. That's one of the clue there. And the duration is very rapid, 1 hour. So you can have other differentials, as you said, peripartum cardiomyopathy or what else you have said, pulmonary embolism. Um, Somebody has said AST. Um, that can be a valid differential, but I think the most probable or provisional diagnosis is an amniotic fluid embolism, where the patient was traveling all right, but 1 hour post the delivery, she started to have symptoms that is consistent with tachycardia, tachypnea, hypotension, right? And with a right-sided dilatation, right heart dilatation. Somebody has written a D-shaped septum. You cannot make out a D-shaped septum with this because that's a short axis view, not a long, not a four-chamber view. This is a four-chamber view. You cannot make out whether it is a D-shaped or not. Definitely, you can make out whether it is dilated or not, but D-shaped. Don't talk about D-shaped in a four-chamber view. If you say that, then it will go against you, and then they will try to drag you in there. Somebody has written as a treatment, yes, IABP VA ECMO, yeah, that's correct. Because it is refractory to vasopressors and inotrope, then the choice is a VA ECMO or IABP in the context of RV dilatation. I don't think it's a choice, but definitely VA ECMO will be the next stage of treatment or escalation of treatment. All right. That completes my part to discuss about 5 CBS very briefly. But the essence of the thing is you will be asked a varied type of question in the CBS because they want to see how you are good in every aspect of critical care. And please do not neglect the minor subjects like ICU administration, ethical principle, end of life care. Those are very important because you will get 2 or 3 CBS from those type of questions, those type of chapters. All right.
So the CCS, as Dr. Sanand has told, this would be something which would be definitely high scoring. And now the European examiners, they are keeping the real exams. Those are actually their own cases in their respective ICUs, and they would be making it all fresh, new cases. So please don't feel that yes, you have some of the old questions with you, and some of the groups they have shared some of the last previous years question papers. So that would be definitely helpful to you. No, so they would be coming up with very unique, and sometimes also it would be complicated, how to go ahead and answer in a proper way. So the examiners are also not very sure what should be the right answer, what should be the wrong answer. So I am having one, I would say, prototype CCS for you all to go through, because it's a mock free webinar. So I would be only going ahead with only one CCS, but I would try to enter into all the possible complications that a patient can have in an ICU. And that's the way the European examiners also look at the examination. That as an attending, as a consultant in your ICU, how confident you are when the patient develops some of the complications from a very straightforward diagnosis. So, if we'll start with the vignette 1, a 62-year-old female shifted to your ICU with shortness of breath since last 1 hour. She was admitted in the hospital for fracture left proximal tibia, for which ORIF was planned. She is a known case of diabetes mellitus on oral hypoglycemic agents since last 6 years. At arrival to the ICU, the vitals temperature is febrile, heart rate is 134 per minute, BP 102 by 56 millimeter mercury, SpO2 95% on HFNC, and on examination she is conscious, oriented, but definitely tachypnic with respiratory rate 35 per minute. And this is the chest X-ray that you got when the patient is in the ward. Now, when the patient is in your ICU and the examiner has shared with you this clinical scenario, the vignette, so what is right now going in your mind? Because the examiner would be showing you this clinical vignette as this is the first vignette, so he or she may share it for a little bit of longer time. So the best thing, once you are getting this clinical vignette one from all the examiners, what we have got the feedback and our own experience, the next maybe 30 seconds, you have to think about what are the salient features or the striking features that you are actually getting from this clinical vignette. Now, from this scenario, that is right now concerning for me, which would be helpful for the answers in my maybe next 20 minutes or so. Shortness of breath since last 1 hour, this is striking, and fracture proximal tibia, for which ORIF was planned, but definitely ORIF could not be done. She is a known case of diabetes, and the arrival, the ICU, the vitals, heart rate 134 per minute. This is something which is really striking to me. Blood pressure is borderline, but saturation 95% on HFNC. Yes, this is also striking to me, and patient is really tachypneic. So these are something which is right now more important for me. And yes, these are some of the clues from the clinical scenario the examiner has shared with you. So you have to scan quickly. So this is something what we are actually sharing as mantra. So once you are getting the clinical vignette, don't jump to the like, yes, this is a pneumonia, something like that. No, please read the sentences, taking maybe 15 seconds more before concluding your provisional diagnosis. Because once you are fixed up with some or other your or the pre-fixed ideas, then the examiner in the subsequent clinical vignettes may be giving you some or other clue, but you are not actually accepting. Your brain is not ready to get that frequency. So that is something what we have gathered from so many of the examinations that we have conducted. Now, the questions from the examiner, this is a mock test. So I am giving you some or other the questions that can come in this clinical scenario. What are your differential diagnosis? This is something which would be coming as the first question. So don't jump to, yes, this is a case of pneumonia. This is something like no, the aspiration pneumonia. This is something like no pulmonary embolism. No. Try to have a structure while you are answering. So in this question, if the examiner has kept 4 marks, so he or she would be expecting that you are answering in this format. My differential diagnosis on the basis of whether it is infectious, whether it is non-infectious. Non-infectious, the most important things, fat embolism syndrome, because this is of short duration, again planned for ORIF, history of trauma. So all these things would be definitely pointing towards that, yes, my patient is having some or other non-infectious cause. So fat embolism syndrome, pulmonary embolism, pulmonary edema, ARDS. In the infectious cause could be aspiration pneumonia, and as such the hospital acquired pneumonia, or maybe a viral pneumonia patient has come from the community with community acquired pneumonia, something or other. Now the next question from the examiner, what is your immediate line of management? As we are intensivist and you are the attending for that day, so definitely the examiner would expect that you should know what are the priorities that is right now in front of you. So your answer should be now again focused. Treatment, investigation. Treatment would be coming as it is in emergency situation, patient has shifted to your ICU. So it would start with ABC, airway, breathing, circulation. Don't utter the word ABC, because again the examiner may feel that you are taking it so lightly. So try to utter the word, I would take care of the airway, breathing and circulation. That itself is self-explanatory at least the consultant level examination. Now next one, IV fluid, empiric antibiotic, consider anticoagulation, because the first differential diagnosis in my mind is fat embolism syndrome or pulmonary embolism. The patient was immobilized in the ward for the ORIF surgery. That patient has not been operated. So the thing that is right now coming in everybody's mind is consider anticoagulation, and then investigation. Definitely after stabilizing, I would be immediately sending some or other samples for some of the tests. Now, this is something what I thought about sharing with you, though it has no relevance to our case as such, that whenever any examiner in any of your examination, not only in the Edic 2, so they would be asking the differential diagnosis, always go ahead with a syndromic approach. What do you mean by syndromic approach? Syndromic approach, if the patient is having encephalopathy, sudden unconsciousness, sudden weakness, seizures precipitated in the hospital, in the ward, in the emergency department. So they have some or other syndromic approach. If the patient has developed shock in your emergency department, presented to your emergency department with hypotension 60 by 40 millimeter mercury with some or other history, patient has developed bleeding, maybe the postpartum bleeding, maybe a patient has suffered trauma and now admitted to your emergency department with bleeding. Now there would be another situation also, hypoxia. Patient is presented to your hospital, your emergency, your ICU with saturation of 70%, and you have started HFNC, you have started BiPAP, you have started the patient on HFNC, then later on converted to the intubation. So these are some of the situations the examiner may frame in their clinical vignette. So you have again the syndromic approach. Now there would be another system which is the renal system, or may be resulting from hypotension, may be resulting from sepsis, or may be resulting from some or other multi-organ failure. Patient will be developing anuria or oliguria. So again there would be a syndromic approach. Now how your answer should be actually framed. Now if I would be now focused with the neurologic part, so my concerns would be, as I have already mentioned, encephalopathy or unconsciousness, that would be the first thing, weakness and seizure. Now in the examination you may start with always a structure: central, peripheral. In the central, infective, non-infective. In the peripheral, again infective, non-infective. I'm not going into detail. This is just to give you an idea that examination, the exams have to be structured smartly, rather than you have to answer quickly and you think that you will get out of four marks. No, the examiner wants that you have the syndromic approach or a structured approach to the problem. You are not a resident who would be jumping to the diagnosis. Rather, you would be connecting the dots well, so that you can get the conclusion automatically rather than prefixed ideas. So this is something which we wanted to share with you guys. Now, the second problem, which is related again to the CNS system or the peripheral nervous system, is the weakness. Now, in the weakness, again, it can be central cause, it can be spinal cause, it can be peripheral cause, it can be again muscle or myopathic related, or some or other drugs, some or other miscellaneous causes. Now, if we will be discussing the seizure, the patient which presented to your emergency or your ICU with seizure, again, it can be central as well as peripheral. So now you have to extrapolate your answer to the causes of central, the causes of peripheral. I'm not going into detail. Now, the second syndromic approach that I have shown, these two slides before, is shock, or the patient will be presented with hypotension. So now the shock can be of mainly cardiogenic, hypovolemic, distributive, and obstructive. So you cannot just right now, whenever the patient is presented to shock, you will be saying that my patient is having septic shock. No, you have to maybe reduce your diagnosis in some or other this type of approach. Now in the cardiogenic, it can be infective, non-infective. In the infective, it can be myocarditis or septic cardiomyopathy. In the non-infective, if you see here, it can be vascular, it can be drugs, it can be arrhythmia, it can be mechanical cause. Maybe in terms of the HOCM, in terms of cardiac tamponade, something like that. Now, there would be another cause which is hypovolemic, which is straightforward, hemorrhagic and non-hemorrhagic. Now, you see the distributive part. If you see the distributive part, again, we have already in our training period, we know what are the distributive causes: septic, SARS, neurogenic, anaphylactic, drugs and toxins, and endocrine causes. Now, the obstructive part is again pulmonary embolism, that is pulmonary cause, and some or other mechanical cause like pneumothorax, like cardiac tamponade, some or other like the outtake dissection, something like that. Now, the next syndromic approach, which would be again the differentials you need to remember, always go in a very structured approach. Like hypoxia, it can be due to VQ mismatch, it can be due to right to left shunt, it can be reduced PiO2 or the pressure of the barometric pressure, hypoventilation, diffusion defect, increased oxygen extraction. So these are some or other causes. I'm not going into detail. The reason why I thought about sharing these slides, that always whenever the first question the clinical vignette will be asked, they would be definitely asking you what are your differential diagnosis, how will you approach the case. So if you start in very much structured approach that I have showed to you, so you will not forget the most important things. Rather, somehow during your answer also you can get to the or you can reach to the correct answer if you have not started with the right answer in your mind. So this is the concept that we wanted to share. Now the last thing that the syndromic approach that I have showed to you is anuria or oliguria or renal failure. We all know the causes of anuria or oliguria or AKI as we will be making it very much scientific way. Pre-renal, renal, post-renal. In the pre-renal, we all know the causes, renal, and then the post-renal, the obstructive uropathy. Now, you can see here the questions that came in my clinical vignette. What investigation would you advise? That would be the third question. Definitely after the initial the diagnosis, the approach, the investigations. In the investigations, again you have to answer in this format: blood, imaging, and others. In the blood, CBC, RFT, D dimer, CRP, procalcitonin. Everybody knows why we are sending this type of things. Imaging, Doppler ultrasound, echo, and in other definitely we need to have one ECG. And if you are answering all these three things, then you will get a 3 mark here. Otherwise, you feel that you have uttered the Doppler ultrasound thinking that it is pulmonary embolism or fat embolism or echo, but you are actually getting only 1 mark because the question is what investigations will you advise? You will not go ahead with only one investigation here at this point. Now, as you have already mentioned about the bedside ECG and echo, so ECG showing sinus tachycardia, echo is mildly dilated RARB and good LV systolic function. Now the next question would be what will be the next investigation? Now the next investigation is CTPA. We all know now at this point of time I am focused for the CTPA, that is the CT pulmonary angio. Now CTPA done, as you have mentioned, now there is again a clue or catch here. If you are not answering CTPA, maybe the examiner would not utter the fifth question here. Again, this is a probable thing scenario because I have gone through my Edic 2 exam where the answer was the examiner expected I should be uttering the word CRRT. But if I have not uttered the word, the next clinical vignette is completely on CRRT. So the examiner would be skipping the CRRT clinical vignette. That could be. So it's not 100% sure, but definitely if you are not uttering or thinking about CRRT, then the examiner has got all the right to think about that you don't know the place of CRRT in this situation. So let's forget about that. We will be doing the CTPA here and the CTPA done. There is no feature of pulmonary embolism and you are getting bilateral pulmonary infiltrates. So what will be your diagnosis? So it is fat embolism syndrome as we have reached to the diagnosis. Now, the investigation format always think about again. This is one the syndromic approach or structural approach that we wanted to share with you. Always start with the blood, microbiology, imaging, and others. Blood, we all know CBC, RFT, LFT, coagulation, CRP, procalcitonin, TROP-T, TROP-I, D dimer, all these are blood tests. Now, coming to the microbiology, it is all related to the samples, whether it is blood or urine or sputum or some or other the biofare, viral, atypical bacterial serology. So, immunofluorescence, all these are microbiologic the sample testing. Now, there would be another investigation format that is imaging, ultrasound, echo, CT scan, MRI, all these things would be coming in the imaging. And there are some special tests that you need to do. So that would be coming in the special investigation format. Now, in our case, if you have uttered the word fat embolism syndrome, so what are the criteria for fat embolism syndrome? So this is something very theoretical. If you know fat embolism syndrome and the criteria, you would be immediately answering. This is Gold and Wilson's criteria, Schoenfeld scoring system, Lindex criteria for fat embolism syndrome. Again, I'm not going into detail, but yes, this has both major criteria, minor criteria. How will you go for the major criteria and minor criteria combination? That is something which you need to remember. And what should be the score? That would be suggesting that yes, this patient is actually high probable for fat embolism syndrome. Now, once you have diagnosed it with your scoring system, what is the definitive treatment for the fat embolism syndrome? I wanted to now somehow focus your attention that how the questions are framed. Have you ever thought about it? So this is something how you are actually addressing the problems at the bedside as an attendee. So that's the same thing, similar thing the examiners also expect from you, as you are the I would say the future boss of your ICU, and definitely the examination would be conducted like this. So definitive treatment plan, the first one would be oxygen aiming at a SpO2 of more than 94%. Your blood pressure has to be targeted map of more than equal to 65. So IV fluid plus minus vasopressor. Early fixation of fracture. This is the definitive treatment plan. And then heparin, as it is fat embolism syndrome. So definitely you have to think about the low molecular heparin or the unfractionated heparin. And corticosteroids, it has a controversial role. So somebody is asking about definitive treatment plan, so you may skip this answer. And if you are answering all these things, you will get a full 3 marks. Now, name two precipitating factors for fat embolism apart from trauma. So this question is something like they wanted to know that actually you know about other the etiology of fat embolism or not. Because always we feel or we correlate trauma with fat embolism, but it's not like that. So there are also some other non-traumatic causes like acute pancreatitis, total parenteral nutrition, if the patient is on parenteral nutrition for a long time, liposuction surgery, sickle cell disease. These are some or other precipitating factors for fat embolism. What is the clinical triad of fat embolism? It is always, you have to remember, dyspnea, confusion, and petechial rash. So if you answer it immediately, 3 plus 2 plus 3 plus something like your answers would be just added, and you will be going up in the ladder in your mark sheet. Now coming to the Vignette 2, the story doesn't end with fat embolism. That is the crux of Edic 2. So they will not stop that yes, you have diagnosed your fat embolism syndrome, now you will get 100 out of 100. No. So they will complicate now your case. Day 3 in your ICU, patient remained to be hypoxemic, hemodynamically stable. You have started on subcutaneous heparin 5000 units 3 times a day. Now, the patient's ABG, pH 7.37, PCO2 32, PaO2 67, saturation 92% on HFNC with bicarbonate of 20.5. The lab investigations are right now at this point of time hemoglobin 10.2, TLC 16,000, platelet 98,000, urea 22, creatinine 1.02, D dimer 1200. Now the HRCT thorax has been done and you are having the report or this film like this. Now suddenly what happened? Patient complained of severe pain in the affected limb which was not there before, and it did not subside even after giving IV analgesics with paracetamol with tramadol. On examination, the limb was tense and there was decreased sensation as compared to the unaffected limb. And surprisingly, there was no reliable pulse oximeter waveform also. So again, whenever you are getting this vignette, don't just read the lines. You have to scan it. You have to scan it. That's why I have made it all red. In your examination, you may not make it red, but in your mind, you can make all these red, black, and white. Okay. Now, what would be the cause of severe pain? The next question expected from the examiner. The first thing that is correct as well as coming in my mind is acute compartment syndrome of the limb. Cellulitis, DVT, acute limb ischemia. And we all know the reason behind why I'm labeling this patient as acute compartment syndrome. Patient is having trauma, then the patient is having immobilized fracture. Again, you have started this the low molecular heparin or subcutaneous heparin. Patient is prone to develop your the thrombosis. So maybe this patient has developed acute compartment syndrome. What will be the immediate investigation? Venous and arterial Doppler. This should be the answer. Don't go here and there. This would be confusing to the examiner and you will be also confused. Then, what would be the next important investigation? Once you are talking about acute compartment syndrome, definitely the examiner would expect that you are thinking about that my patient is now going into rhabdomyolysis or compartment syndrome leading to decreased perfusion and muscle damage. So, CPK, RFT, urine analysis, urine myoglobin, and coagulation test. Definitely, if there is some or other hypercoagulability syndrome, so you will get that from the coagulation test. You are answering these three things, you are getting full 3 marks. Now, you utter the word Doppler. Next question is about Doppler. So you can see your answer is actually the question of the next number. You are saying acute compartment syndrome, immediate investigation would be Doppler. You are saying it is to be Doppler, so the next question is Doppler was abnormal and SCS was provisionally diagnosed. What are the criteria for SCS? The next question is acute compartment syndrome. Now, as we always prefer structured answer, don't utter the word pain, then somebody would be telling no firm compartment, then weakness. No, always have a framework in your mind. Pain, paresthesia, poikilothermia, pallor, paralysis, pulselessness. I have talked about 6P to answer your question. Pain, paresthesia, poikilothermia, pallor, paralysis, pulselessness, significant extremity pain, which is out of proportion to your injury, then it would be progressing rapidly, tense firm compartment on your clinical examination, and then whenever you are stretching your muscles, pain is actually exacerbating. And then again, depending upon the specific the framework or the neurovascular finding, you can get the paresthesia, decreased pulse, and muscle weakness. So if you are answering all these things in a proper way, you get a full 5 marks. Now, the next question, once you are talking about that, yes, this is something like no tense form compartment, the examiner would ask you what is delta pressure and what is the cutoff value for the fasciotomy. So in the acute compartment syndrome, the delta pressure is diastolic blood pressure minus the measured compartment pressure. And roughly, if it is exceeding 20 to 30 millimeter mercury, depending upon the clinical examination, this indicates what is the value or what is the importance of this, this delta pressure. This would be highlighting the need of fasciotomy. Now, what is the management of the limb acute compartment syndrome? Again, go ahead in a very structured way. General management, specific management, experimental therapy. General management, frequent serial examination, remove all external pressures. If there is some tight bandage or something splinting, you have to immediately remove it. Supplementary oxygen, analgesic, IV fluid, avoid hypotension. Now the specific management, as it is due to this the fracture, trauma, immediate surgical consultation, fasciotomy, and experimental therapy is hyperbaric oxygen. Now, what is the indication of fasciotomy? Already the question have been dealt here. High clinical suspicion, compartment pressure within 30 millimeter mercury of diastolic pressure. Now, the question or the clinical case doesn't end here. The examiner would now complicate it further. As the patient became tachypneic, she was put on NIV. The lower limb swelling gradually decreased with conservative management. So you are happy. But on day 5, she developed gross abdominal distension and was unable to pass stool for the preceding 72 hours. So from this fracture, they entered into the hypotension respiratory distress, that is the fat embolism. From fat embolism, they entered into the limb, making it acute compartment syndrome. From acute compartment syndrome, they have now entered into the tummy. So this is something is unique for the Edic part 2. So now on examination, you can see here heart rate 122, BP 124 by 82, saturation 95% on NIV, GCS E4 M6 B5, chest bivessel crepes, abdomen, which is the significant thing for this clinical vignette 3, distension, tympanic on percussion, bowel sound sluggish, and last bowel open 2 days back. So they have given enough information from the history as well as on examination. When you did the lab investigation, you can see here hemoglobin 10.C 14,200 TLC, platelet is dropping little bit further 76,000, urea creatine seem to be okay, potassium 2.9, magnesium 1.47. Again, they have given you enough information to expect the right answer from you in the next clinical case question that would be coming. Now, if you will be going ahead with the question would be what are the causes of abdominal distension in this patient? One would be colonic pseudo obstruction, and we have enough clinical hints that is suggestive of that are suggestive of that this patient is having pseudo obstruction or Ogilvie syndrome. Now, any other relevant pathology. Now, how will you further investigate? CT abdomen, abdominal X-ray, colonoscopy. What is your provisional diagnosis at this point of time? Acute colonic pseudo obstruction. What is your management plan? Again, the management plan, as we have already told, management plan would be general management, specific management, and some or other the things that is specific to the Ogilvie syndrome. In the general management, correct the hypokalemia, hypomagnesemia, stop narcotics because the patient is on with pain for the acute compartment syndrome. Definitely you have used tramadol, you have used fentanyl, you have used some of the opioids. So that is also one of the etiology for your colonic pseudo obstruction. Now, start ambulating the patient early, control the blood sugar. This is the general management. First up, BIDS. Look how clever the examiners are. So they wanted to know that you are actually thorough about the general management plan also in your ICU daily round, like first up BIDS. Now, coming to the specific management, drugs, you have to start with the pharmacotherapy first, metoclopramide, erythromycin, or neostigmine. And the intervention part, you have to put NG tube, put the patient on NBM or NPO, put one a flatus tube, and consideration for colonic decompression. What are the role of colonoscopy? Again, structure. Diagnostic, therapeutic. Diagnostic, first one to rule out distal obstructive lesions. But yes, we all know diagnostic cause you are doing colonoscopy, they have their own the complications associated with some of the colonoscopy. You are pushing some of the air into it in insufflating, so that may cause the colonic rupture. So that is again one complication. Now, therapeutic colonoscopy decompression. Now, what are the indications for surgery? If after this colonic decompression also the colonic dilatation is persisting, so definitely you have to go ahead with the surgery. Perforative peritonitis or abdominal compartment syndrome. Now, what are the biochemical abnormalities now here? They would be asking rise in TLC, thrombocytopenia, cholestatic jaundice, coagulopathy. These are some or other questions they can ask. What are the differential diagnoses? Sepsis with MODS, bowel ischemia. Now, there is the question. They would be now showing you something like the patient has developed oliguria. So, what are the diagnoses of or the indications of dialysis in this case? They may ask you. So that would be metabolic acidosis, oliguria, hyperkalemia. And in this patient, when the patient is right now landed up in the colonic pseudo obstruction with multi-organ failure following fat embolism syndrome. So what type of dialysis is preferred and why? So CRRT or SLADE because the patient is not so much hemodynamic unstable. So that you can answer. Now, story doesn't end here. Now from the tummy, they wanted to enter into the brain. So SLADE was started in view of worsening metabolic acidosis and hemodynamic instability. Patient was intubated because the patient is right now having poor GCS, probable septic or metabolic encephalopathy. Now, she was maintaining on 40% oxygen with PEEP 6. Okay, acceptable. Now, she was on fentanyl infusion and urine output was only 20 ml per hour since the onset of dialysis. and he was on 10 mics noradrenaline infusion. ABG done 7.31, 34, 18.4, saturation 97% with lactate 2.1. Sodium 154, potassium 3.85. Now, in the morning round, the resident doctor was happy about increased urine output in the last 2 hours, 120 ml per hour. But immediately you got the information from the nurse that pupils are right 4 mm sluggish and left 2.5 mm reacting to light. Now you did the urgent CT scan and you are getting the picture like this. Okay. Oh, this poor man has suffered everything in her life. Like no, this lady. Okay. So what is your diagnosis? Diffuse cerebral edema, cisternal SH, and what is your immediate management plan? Neurosurgery consultation, 3% saline, mannitol, head and elevation, hyperventilation, and what are the likely cause or etiology of sudden deterioration in this case from the CNS perspective? The worsening hypotension, intracranial hypertension, hypoxemia, or HIE, because maybe the dialysis has started and the patient has been on the anticoagulants and something or other, like no, the mismatch has happened. The patient has suffered hypotension or bleeding that led to the cerebral edema, intracranial hypertension, and could be the reason for the sudden deterioration. Now, one of the family member asked, now what is the outcome of my patient? You have like no visited all the systems in last like no 5 days, so what is the outcome? So definitely now the examiner wants to know that how comfortable or confident you are to answer the queries after 6 days of ICU admission and the patient has landed up in some or other complication that has happened during the course of the treatment. So this is the communication part. I'm not again going to this details: setting, perception, invitation, knowledge, empathy, and summary. I'm not going to again complicate it further. The patient should be now, I think, in the safe hands of you all, and we have managed well. If you reach to this point of time, so the examiner would be definitely happy that you have tackled it very well and you have answered it confidently, and you are ready to be the consultant in charge of your ICU. So thank you very much for your patient listening. I hope the message is very loud and clear, though I have tried to make it complicated, but this is something if you prepare well and you sweat in peace, rather like no, you have to like no take the need of like no bleed in the war. Okay. Yeah, Dr. Ajmat, concentration and focus. Yeah, they want to only check that as the attending as a senior most guy in your ICU. So you have got that like no the coolness in your mind to answer the complications again, like no handle the complications, and then again clarify the queries to the family. So again, all the things they want to know. That's why you are a complete intensivist.
So
Tell
I
him.
think so. We have participants up to around 26 of them. So I think I've already put a message in the group. So my sincere request is like be focused and at least daily do some like a mock exam, or and you have the like videos of all our on the modules. So please go through that. Don't think that in the last 1 week I will sit and do and all that. No, it will not happen. So because and your approach, your focus, your thought process like should be towards the exam. So then only you can on the crack. I know that people have the like fund of reading for the like last 1 week and doing all that. No, it won't actually work here. And from now on in your ICU, and you should actually deal with all the patients whoever get admitted to intensive care the same like a exam. What's your differential diagnosis? What's your plan of action? So if any complications happen, how do you deal? And whatever you speak to the family, the counseling part, uh, make it as a habit that and you're giving an exam and you're doing that. So then your the exam stress, exam fear will go away. And if you have friends along with you who are giving exam, or you are and the juniors, sit with them and answer them. See, I understand all of you are working in ICU and you know how to deal with all these patient scenarios. But if you don't vocalize it, if you don't practice how to vocalize it, and you will not actually do well in the exam. So please be focused. And I think when you guys know about all the CBS and the CCS, the most of the things, don't think about the rarest things here. Okay, if at all, if you have the 15 on the CBS questions, in that the 12 will be the most common one, and the 3 will be some uncommon things. So concentrate on the like 12, the common ones, somehow with the unknown or the least common one, and you might actually do a uh, guessing work there. Okay, but be sure, and you know all the systems how it runs. If it is a under CNS, TBI, stroke, or myasthenia gravis, autoimmune encephalitis, and all that. And then comes the CVS. It's all cardiogenic shock, MI. Then comes the procedures, ECMO, and all that. So it's all, and you guys know it very well. So but the main thing is you should be like focused, and you have around 45 days the time now. But please make sure and you are uh, disciplined, and you will be go along with some plan of action. So make a plan for the next and a few days how to go ahead. Okay, thank you.
Yeah, so yes, as rightly told by Dr. Manjunath, one of the core faculty member. So the answers to all the questions, you have to start with the most important thing first, rather than rarest things, as Dr. Manjunath told. And the examination would definitely boost up your confidence when you are actually answering in front of the mock examiner, who would be like sitting online somewhere else and asking you the questions. So how you are actually framing your answers? It's always like better to have practice, 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 practice. You go straight forward to the examination, and the examiner would ask you here, there, north, south. So you would be completely confused, and you will be not focusing also rightly in front of the your computer. And there are multiple things apart from clinical or knowledge, as Dr. Ajmat told in the posted in the group. So there are also sometimes you have to troubleshoot your internet connection, like your volume, how you are actually answering, and the examiner is unable to listen to you, hear you. So these are some or other the logistic problems or the technical things that also you need to prepare well in the mock test, rather than going straight forward to the examination, and the European examiner will be asking you in again the accent, how the examiners are asking you the questions. Sometimes we got feedback also that the examinees are actually unable to understand actually what actually the examiner is asking, or they want to know. So that also is another part, that you have to listen to many of the examiners in their different accents or dialects. So then only you will get to know, yes, hypotension, he is asking about what is the cause of hypotension, something or like that. Okay, so thank you very much. We are almost 1 hour or 5 minutes, and we have completely gone through the format. We have already planned our examination. Though the flyer has mentioned 20th September, but we are starting from 3rd of October, and it would go non-stop. Every day there would be 3 to 4 slots, and the examiners and the examinees would be connected via Zoom, and definitely it would be having a very good the coverage of all the important the CCS and CPS, and the confidence checking, and all the the logistic technical things also, that would be before your November 26 and 27 exam. So any queries, it doesn't stop here. We have the WhatsApp group also. Please post. We are happy to help. Whether you join or not, that's not very important. Rather, you all should clear in your the next the attempt, that is on November 26 and 27. Thank you all for your patient listening. Wish you all the best for your upcoming exam. Thank you, Dr. Manjunath. Thank you, Team 360 Critical Care, Dr. Sanand, and
Thank
all the
you.
delegates for the you are joining on time and staying till your 1 hour and 10 minutes. I hope this serves the purpose for which we have actually conceptualized this.